Hi, my name is Chase Garrett, and today is August 4th, 2020, and this is my Unit 2 case connection. I'm going to start off by talking about case 2. The above MRI shows a large glioblastoma tumor with areas of necrosis within the tumor. On the right is a PET scan from the same individual following administration of fluorescently labeled D-glucose. Before we discuss the tumor and cancer cells, we are going to look at how certain parts of the body normally uptake glucose. It is important to note that glucose uptake occurs in the fed state because the present glucose is brought into the cells, hence why it is called glucose uptake. In the liver, GLUT2 sits on the plasma membrane of the cells. It is always present even when insulin is absent. This means that this glucose transporter is not insulin sensitive. GLUT2 is specifically used to bring glucose into the liver so that it can be used in glycogen synthesis. In skeletal muscle, GLUT4 stays inside intracellular vesicles until insulin is present. In other words, when insulin binds to its cellular receptor, GLUT4 is relocated to the plasma membrane. After this, GLUT4 is able to bind to glucose and transfer it into the cell. Within the cell, glucose is phosphorylated into glucose 6-phosphate, so it doesn't have the capability to leave the cell. In skeletal muscle, hexokinase is responsible for this. In the liver, glucokinase is responsible for this. In both the liver and skeletal muscle, glucose 6-phosphate is isomerized into glucose 1-phosphate. Following this, glucose 1-phosphate will undergo glycogen synthesis via glycogen synthase. This will produce glycogen that can be stored within the cell. In the brain, GLUT1 and GLUT3 participate in something known as the astrocyte to neuron lactate shuttle in order to transport glucose. GLUT1 is located in endothelial cells and astrocytes. Astrocytes take glucose from blood using GLUT1 and metabolize it into lactate. Lactate is then transferred to neurons via monocarboxylate transporters. GLUT3 is located in these neurons. It is used to transfer glucose into the neuron. Lactate and glucose are then both used to make pyruvate, which can be used to generate ATP. Adipose tissue uptakes glucose in almost the exact same way as skeletal muscle. This is due to the fact that they both use GLUT4 to transport glucose. It is important to remember that GLUT4 is insulin sensitive. Now we're going to discuss how cancer cells affect glucose uptake. Cancer cells cause an increase in glucose uptake because of something known as the Warburg effect. Normally functioning cells primarily rely on oxidative phosphorylation to generate energy, or ATP. The Warburg effect is a name given to a phenomenon where cancer cells prefer to use aerobic glycolysis rather than oxidative phosphorylation. Aerobic glycolysis is an inefficient way to generate ATP, so it is a mystery as to why this occurs. Although the reason cancer cells use aerobic glycolysis is unknown, some scientists theorize that cancer cells are using nutrients in cell proliferation rather than ATP production. Additionally, the activation of certain oncogenes increases glucose uptake. It does so by inducing increased activity of glycolytic enzymes and GLUTs. This explains the bright orange area of the PET scan. In a PET scan, D-glucose is administered to the patient. Then the patient is scanned to see where the glucose is most abundant. Since glucose uptake is increased in cancer cells, the D-glucose will be most abundant in the cancer cells. In a PET scan, a bright orange spot in the shape of a tumor will be shown. This is apparent in the PET scan given in the assignment. Now I'm going to move on to case 4. In case 4, we discuss the health of a 2-month-old female. She comes into the doctor's office with multiple symptoms. These symptoms include jittery spells after breastfeeding, recent increase in sleep amount, hypoglycemia, hepatomegaly or enlarged liver, and the inability to maintain normal blood glucose levels. Additionally, when epinephrine is administered, there is no increase in blood glucose. but there is an increase in blood lactate. Epinephrine stimulates the breakdown of glycogen or glycogenolysis. Ultimately, glycogen will be broken down into glucose, lactate, or acetyl-CoA and CO2. To diagnose the child, I will compare the symptoms she has to the symptoms of the disorders given in the assignment. The first disorder is hereditary fructose intolerance. Hereditary fructose intolerance affects the ability for a person to digest the sugar fructose. A person with this condition may experience nausea, bloating, abdominal pain, diarrhea, vomiting, and hypoglycemia after ingesting fructose. If the person repeatedly ingests fructose, they will cause kidney and liver damage. Because of this, they could develop jaundice, hepatomegaly, and chronic liver disease. Despite some similarities in symptoms, the infant does not have hereditary fructose intolerance. There are a couple of reasons for this. First, the patient only has a couple of the symptoms. She lacks the majority of the symptoms, i.e., nausea, diarrhea, bloating, and others. Additionally, this disorder does not account for some of the symptoms she has, such as an increase in sleep. Lastly, the most important reason that she does not have hereditary fructose intolerance is the fact that breast milk does not contain fructose. It contains the sugar lactose, a disaccharide of glucose and galactose. The mother indicated that the infant is only consuming breast milk, which means that there is no fructose in the infant's diet. Thus, the infant does not have hereditary fructose intolerance. Next disorder is galactosemia. Galactosemia is a disorder that affects how galactose is metabolized. There are multiple types of galactose, the first being classic or type 1 galactosemia. This specific type causes a person to develop feeding difficulties, lethargy, failure to thrive, jaundice, liver damage, which tends to cause hepatomegaly, and abnormal bleeding. Additionally, an infant with this disease will develop cataracts. The infant in this assignment does not have this disease because some of the symptoms of this disease do not match up with the infant's symptoms. For example, the infant in this assignment does not have cataracts, so the disease is not present. Also, this disorder does not explain why blood lactate increases with the administration of epinephrine, but blood glucose does not change. The next disease is glucose 6-phosphate dehydrogenase deficiency. Glucose 6-phosphate dehydrogenase deficiency is a genetic disorder that causes red blood cells to break down quicker. Patients with this disorder commonly have poor tolerance to fasting, hemolytic anemia, paleness, jaundice, dark urine, fatigue, shortness of breath, and a rapid heart rate. While some of these symptoms match, there is one problem with this disorder. Much like galactosemia, it doesn't explain why blood lactate increases with the addition of epinephrine, but blood glucose does not. Glucose 6-phosphate dehydrogenase is used to convert glucose 6-phosphate into 6-phosphogluconol acetone. A deficiency in this enzyme would not cause blood glucose levels to not increase when epinephrine is administered like they normally would. So, the infant does not have glucose 6-phosphate dehydrogenase deficiency. The last disease is to consider is glycogen storage disorder or disease, glycogen storage disease. There are multiple types, but the one affecting the infant is von Gerk's or type 1 glycogen storage disease. Von Gerk's disease causes the patient to have the following symptoms: hypoglycemia, lactic acidosis, hepatomegaly, high blood levels of uric acid, excess amounts of fats in the blood, and diarrhea. Despite the lack of some of the symptoms in the infant, von Gerk's disease is most likely the disease affecting her. This is because von Gerk's disease is also known as glucose 6-phosphatase deficiency. A deficiency in glucose 6-phosphatase would explain why the administration of epinephrine increased the amount of lactate being produced, but did not increase the amount of glucose being produced. In glycogenolysis, or the breakdown of glycogen, glucose 6-phosphatase is responsible for converting glucose 6-phosphate into glucose. Thus, glucose would not be produced if there was a deficiency in glucose 6-phosphatase. So, we know that the infant has a glycogen storage disorder.